Seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Minimize this. Okay, good. All right, so yeah, okay, so we'll go ahead and get started. Sorry for the delay, everyone. This is Pratik. I'm Karina next to me. So today we're going to talk about GERD or gastroesophageal reflux disease. So next slide.
All right, so we figured we'll start off with talking about the anatomy a little bit. So as you see here, we have the esophagus and the stomach. And with gastroesophageal reflux disease, we usually have the lower esophageal sphincter, which isn't as strong anymore. So it's weakened, and it allows for all the acid and all the fluid to go up, causing irritation to the esophagus, as you can see in the illustration here. Next slide.
So GERD, it's the most commonly diagnosed GI disorder. There's approximately 9 million outpatient visits annually with this complaint, and it results in approximately 100,000 hospitalizations annually. 50% of adults experience some GERD symptoms at any point during their lifetime, and more recently, the incidence of GERD has increased by 50% over the past 25 years, most likely secondary to the increased rates of obesity. And then women and African Americans have lower rates of complicated gastroesophageal reflux disease. Next slide.
So some of the most common symptoms that patients present to us with are heartburn, regurgitation, difficulty swallowing, even coughing. Some patients come in with like a chronic cough for a few months, sore throat, hoarseness, and sometimes even chest pain. Next slide.
So what are the risk factors or triggers of reflux? So as I mentioned earlier, obesity is one of the biggest risk factors. Tobacco or smoking, it damages the mucous membranes and it impairs the reflexes in the throat. Also increases the acid secretion within the stomach, and it reduces the lower esophageal sphincter function and salivation. Food and beverages of certain foods and beverages that worsen GERD, including carbonated beverages, chocolate, alcohol, citrus juices, coffee or caffeinated tea, fatty foods, tomatoes, peppermint, spicy food. Basically, all of the good foods can trigger reflux. Hiatal hernia can cause reflux, and then eating close to bedtime or laying down quickly after a meal can also trigger reflux. Next slide.
And then I figured we can go over some medications that can aggravate symptoms. So there are some medications that further weaken that lower esophageal sphincter that we talked about earlier. So some of the common medications are tricyclic antidepressants, diazepam, calcium channel blockers, amongst others. And then there are some medications that damage the esophageal mucosa, and that includes aspirin, NSAIDs, which are ibuprofen, Motrin, and bisphosphonates as well. Next slide.
So this chart, basically, just to simplify it, it kind of goes over how we, from a GI perspective, sort of manage and diagnose GERD. And so typically we have patients who'll come with typical heartburn symptoms or burning, as well as or regurgitation. They don't have any alarm symptoms such as like vomiting, with blood or blood in their stool, weight loss, difficulty swallowing, any of those things or in the elderly. And if these symptoms present with enough frequency and they're impacting the patient's quality of life, prior to doing any sort of endoscopy, what you can do is trial these patients with once daily proton pump inhibitors, such as like a Prilosec or omeprazole, any of these over-the-counter medications will work fine, or even a Protonix for 8 weeks. And then you assess for resolution of symptoms. If the patient has symptom resolution, then you can consider discontinuing the medication. If they're not resolved, then ideally we would perform an endoscopy off of the PPI for a few weeks. Obviously, this can be very difficult for a lot of patients because coming off of the PPI can lead to worsening symptoms. And so this is the ideal situation. However, I would say the vast majority of patients who come in for initial evaluation, we end up scoping while they're already on the proton pump inhibitor. And then there's certain findings on endoscopy that would sort of verify the diagnosis of GERD. These are listed here. So basically LA grade, which is how we classify esophagitis, and it's graded A through D. And if there's any evidence of B, C, or D, or any evidence of Barrett's esophagus, which we'll get into a little later, that sort of confirms the diagnosis of reflux. If they don't have those findings and you're still having symptoms despite the medication, then there's some other testing that we can do, which we'll get into a little bit later. So next slide.
All right, so how do we diagnose GERD? So by the time the patient comes to see us, they have already probably seen their primary care doctor, and they have been already started on proton pump inhibitors. So if they haven't been started on the medications, we'll trial them, like Pratik said, on the medications. And if they're still not feeling better, we usually set them up for an endoscopy. And at that point, we can take a look into their esophagus, their stomach, and the small intestine, part of the small intestine, and see. And if that doesn't help us, we do something called a pH study, which we'll get into in a little bit. Next slide.
And this is just a simple overview of what an endoscopy sort of looks like. It's basically you're sedated, typically with medication called propofol, and so you're asleep. You don't remember any of the procedure. Once you fall asleep, we slowly insert this basically a camera at the end of a tube into your mouth, and then we travel through the esophagus into the stomach, and then the first part of the small intestine or the duodenum. And essentially we'll take a close look. When it comes to reflux, we're really looking at the esophagus, or the distal part of the esophagus, which is close to the stomach, to look for any evidence of any damage or any changes that would suggest Barrett's esophagus. And if we do see anything, we would take biopsies. The procedure itself typically is about a 5 to 10 minute procedure. And if there's anything unusual or a long segment of Barrett's, that can take a little bit longer. But typically it's a short procedure. And it's a same day outpatient procedure that you go home on the same day. Next slide.
So what are the indications for endoscopy? So like we mentioned before, patients who are not responsive to PPI therapy. And then there's also patients who come in with alarm symptoms. And these alarm symptoms include weight loss, GI bleeding, difficulty swallowing. And so this indicates that their GERD is likely progressive, and we need to go in there and take a look to see if there's anything else we can do. Long history of symptoms, and if these patients have multiple risk factors for Barrett's esophagus, or if they're at high risk for complications. Next slide.
So these pictures right here basically just show what a normal distal esophagus or mid and distal esophagus look like on endoscopy. The top picture is the middle of the esophagus, and then the bottom picture is the distal esophagus, or the GE junction. And you can see a little bit at the bottom where there's like a little change in what the mucosa looks like. That's what we call the Z line, or the GE junction. Next slide.
And then this is some pictures going over esophagitis. So, there's different grades of esophagitis. There's grade 1, as you can see, like little mucosal damage in the lining. Grade B, when there's more greater than 5 centimeters of damage. And then grade C, you can see that it's starting to be almost circumferential, or 75% circumferential, or grade D, where you can see that there's erosions throughout the entire esophagus. Next slide.
And then these are just sort of actual images of what the esophagitis would look like. And so when we were discussing the LA grade system, so N is normal, and then you see the A, B, C, and D. And so when you really see this grade C and grade D, you don't really need any further testing to make the diagnosis of GERD, because it's obvious that the patient has reflux disease that's causing a significant amount of damage to the lower part of the esophagus. And at that point, you can definitively say that the patient has gastroesophageal reflux disease. Next slide.
I think there's a picture of Barrett's esophagus that we've been talking about. There's actually slides. So Barrett's esophagus is basically a condition where the lining of the esophagus changes. It becomes more like the lining of the small intestine rather than the esophagus. And so if we see that, we take biopsies, and if the biopsies do not show any evidence of dysplasia, which means that the cells are changing or transforming, then we likely don't have to follow up with that for a few years. But if there is evidence of dysplasia or metaplasia, then we have to screen these patients, every 2 to 3 years to make sure that this isn't turning into dysplastic cells and even cancer. Next slide.
This slide kind of goes over what I had mentioned earlier about all other testing that we can do to sort of confirm the diagnosis of reflux, especially if there's no evidence of that LA grade C or D esophagitis. And so this test is esophageal pH testing. There's 2 versions of this test. One of them is wireless, and then the other one is catheter-based or with wire. Essentially, the wireless test is basically something that's also called a Bravo pH monitoring. Basically, there's a probe that's attached to the esophagus about 5 to 6 centimeters above where the junction between the esophagus and the stomach is. And that essentially measures the amount of acid exposure time that part of the esophagus receives throughout 28 or 48-hour period. Similarly, the wireless one does the same thing. However, you do have basically a catheter that comes out of your nose, and that stays in there for about a day, and then subsequently removed. And based on the findings of these testing, if they meet certain thresholds, we can make the diagnosis of GERD. Next slide.
So I just wanted to go a little bit deeper into the Bravo pH test because it's most frequently used. So patients typically have to hold their PPIs for about 7 days, the H2 blockers for about 2 days, and any antacids for 6 hours prior to the procedure. And basically, the capsule is deployed in 5 centimeters above the lower esophageal sphincter. This is done with an upper endoscopy, similar to how we do our endoscopy. And then the patients have this on for about 48 hours. And during that time, every time they eat something, they keep a diary. And later, the doctor reviews everything with them. Next slide.
So what are some of the complications of longstanding reflux? So we had gone over the esophagitis pictures before. When you have chronic reflux and chronic inflammation to the bottom part of the esophagus, you can develop things called esophageal or peptic strictures, which is basically a tightening of the esophagus that can at times mimic a tumor because it can cause symptoms of food getting stuck or pain as food passes through the bottom part of the esophagus. Barrett's esophagus, which we went over earlier, which is essentially a precursor lesion to esophageal adenocarcinoma or esophageal cancer. Asthma is another complication, and laryngeal and tracheal stenosis as well. Next slide.
So what are our treatment goals? Basically, we want to make sure the patient doesn't have any symptoms, so eliminate all symptoms. Heal irritation of the esophagus because acid can definitely cause a lot of complications, as Praseek was just describing, and prevent long-term complications of GERD. Next slide.
So what are some of the non-pharmacologic treatments? So you can elevate the head of your bed or use a wedge pillow when you go to sleep. Avoid eating within 2 to 3 hours of bedtime. In obese patients, weight loss is probably one of the best methods of treating reflux. Avoiding tight-fitting clothes around the waist, tobacco cessation, modifying your diet and avoiding those sort of triggers that we had discussed earlier, and then eating more frequent but smaller meals may help as well. Next slide.
All right, so I just wanted to talk to you about some of the medications. So there's the H2 blockers, which you may know as Zantac or Pepcid, and then there's the PPIs, and there's different trade names. So there's like Prilosec, Prevacid, Protonix, Sasifex, Nexium, Dexlon, and they all have different strengths. And we most often prescribe the omeprazole or the esomeprazole. And sometimes, you know, if the patient's not responding to one, we oftentimes switch them and try a different one because not everyone's going to respond to each medication the same. They're usually taken 30 minutes before a meal. So typically in the morning, 30 minutes before breakfast. And if they're taking on twice a day, they could be taken 30 minutes before dinner as well. And the H2 blocker is usually given at night. That seems to help. Next slide.
So this slide, it's a little bit complicated, but basically it just goes over how these medications work, and sort of the main point of this slide is, you know, H2 blockers work in a completely different way than proton pump inhibitors. And so if a patient is intolerant to PPI because of a variety of different reasons, or if they have any side effects, or if they're allergic to one of these medications, a medication in a different class, you know, is perfectly reasonable. As it works in a completely different method. There's also a newer medication that will be coming out probably in the next year or so that works in a different way than PPIs and H2 blockers, and it's actually stronger medication. And so we soon will have another sort of option for reflux disease. Next slide.
So we get asked this question a lot. And our proton pump inhibitors safe long term. So there's been a lot of studies out there, and you know, it's really the most effective medical treatment for GERD. So there's been some studies that have identified an association between long-term use of PPIs and the development of numerous adverse conditions. So pneumonia, stomach cancer, bone loss, kidney disease, dementia, heart attacks, strokes, and patients are quite worried about this. The only one that they have been able to establish a cause and effect relationship has been with the intestinal infections. Otherwise, everything else, a lot of these studies have flaws. So what we tell our patients is that as long as the medication is helping them, they should continue with the medication. Otherwise, if there's, you know, they're no longer symptomatic, we can start to take them off the medication. Next slide.
This slide kind of reinforces what we had gone over earlier, but in terms of what is an acid reflux diet, and it sort of goes over all the things that you would like to avoid if you have reflux disease, such as caffeine, alcohol, fatty foods, garlic, tomatoes, cheese, those sorts of things, and things that would be, you know, appropriate for a reflux diet include rice, ginger, bananas, fruits, those sorts of things. Next slide.
So if medical treatment fails and the patients continue to be symptomatic, there are various surgeries. One of the most popular surgeries on fundoplication, and that targets the lower esophageal sphincter. So basically the gastric fundus, as you see at the top of the stomach, it's wrapped around the lower end of the esophagus and stitched in place. And that reinforces the closing function of the lower esophageal sphincter, which brings a lot of relief to the patients. And there's a few other surgeries that we haven't mentioned here, but that's something I guess they could discuss with their surgical teams.
Dr. Hamilton. And that's all we have. Thanks for joining us. Any questions?
Well, thank you to the both of you. If anybody has any questions, you can email them off to matherhospital@northwell.edu. Once you exit the webinar, you'll see a brief survey. You complete that survey. It'll be very helpful to the Public Affairs Office. If you'd like to view any previous HealthyU webinars, you can see them at www.matherhospital.org/HealthyU. Thank you all so much for joining and have a great